Good afternoon, everybody. Thank you for joining us. My name is Garrett Schmidt. I'm the managing editor for ACO Exhibit Hall, and I'd like to welcome you to today's webinar by Vinca entitled How to Develop End-of-Life Processes for the ACO's Care Continuum. Should be a very interesting topic. I'm looking forward to the presentation. A few items of note before we get started. First of all attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your mic. It'll be done for you. Secondly, this webinar is being recorded, so you'll have the opportunity to rewatch the session and or share it with colleagues after the conclusion. And a link to the recording will be emailed to all the registrants following the presentation. So even if someone registered but was not able to attend, they'll still get a link to that recording. Finally, during the webinar, you will be able to submit questions to our presenter. So feel free to do so, and we will answer as many of those as possible during the Q&A session towards the end. And these questions are also being recorded, so even if we're unable to get to yours during the allotted time, we'll be able to answer it via email afterwards. So without further ado, wanted to introduce our presenter today, Dr. Ryan Van Wert, who's the co-founder and chief executive officer for Vinca. So I wanted at this time to introduce him. So welcome, Dr. Van Wert.
Great, thank you, and thank you for the opportunity to present today. It's much appreciated. I wanted to start just by briefly introducing myself and the origin of Vinca and why we do what we do today, and then move into a discussion around the importance of advanced care planning to improve the quality of care at the end of life for patients who are participants and members within an ACO. I'm a critical care physician, and much of the reason for starting Vinca was seeing end-of-life care delivered poorly at the end of life, seeing individuals with advanced illness, cancers, dementia, and otherwise coming through the doors of our emergency room and ending up on life support, often without any kind of advanced care planning documentation available. It turned out more often than not that if this documentation was found, individuals often got a lot of care that they never asked for. Very traumatic for the patients, of course, for the family members and the providers involved, and certainly an enormous magnitude of cost that is associated with care that individuals never asked for. So I saw an opportunity with three others to really improve, using technology, this whole process of understanding a person's future care preferences and making sure that they are honored. I still practice medicine 1 day a week, but have been spending most of my time with Vinca over the last 6 years. I wanted to start today just by reviewing what advanced care planning is and its value. And one of the real opportunities around advanced care planning is that it hits so many of our metrics and goals within the quadruple aim of healthcare today naturally. So we'll look at that in a little bit more detail and then tell you a little bit about our approach to solving this problem in a complete and end-to-end way, discuss a few of our case studies, and then look specifically at some examples within ACOs. These are just some newspaper clippings that we've taken over the last few years, highlighting how broken the end-of-life care delivery system is in this country. Much of the discussion began back in 2014-15 with the release of the National Academy of Medicine report Dying in America, highlighting many of these points of breakdown. The Gawande book, Being Mortal, certainly brought this to the dinner table in terms of discussion. And we're seeing a lot of articles now around the difficulty of clinicians in finding this information within electronic health records, and even some litigation, not for undertreating an individual at the end of life, but in fact for overtreating that individual. So we take a step back and look at what advanced care planning is. It is a lifelong process of personal reflection and learning to determine and document future care preferences in such a way that these are available to all caregivers. And this is really an aspirational statement of what advanced care planning is, and it's the true definition of patient-centered and patient-focused care. To be successful, though, advanced care planning has to have a lot of aspects that are really challenging to operationalize. These are difficult conversations, difficult concepts, and individuals need help to reflect on their values and hopes for the future, and do this in a way that recognizes variations in healthcare literacy amongst the population. There needs to be ultimately an alignment of what these values are to the person's clinical context and what their treatment choices are within a disease state. Providers are at the front lines of having these conversations, and they need the tools and resources to feel comfortable having them. And then there's a largely state level variation in terms of the legal documentation requirements, and these vary, of course, state by state, and certainly are a challenge to navigate for those that have not looked into the specific requirements. And then finally, once all of this process is done, it really needs to be available universally so that these wishes can be honored within the entire care ecosystem. And this is particularly challenging because many of these conversations will occur in places like a primary care doc's office, a specialist's office, a skilled nursing facility, but where they tend to be needed more often than not to be actionable is in the acute care setting, in emergency rooms and otherwise. And that's a particular challenge around ensuring that after all that hard work is done to understand a person's choices and to document them, that they are universally available. So why is this important? Well, I think first of all, this is the right thing to do for patients. It is a very important time of life, and arguably one where focus on quality is of the utmost importance. This is often a time when families and loved ones are involved, and having an experience that at the end of life for a loved one really has some profound impact on families, not only through the bereavement phase, but beyond. There is also, as I mentioned early on, a lot of unwanted utilization that's associated when patient care preferences are not honored. And much of this is now fitting into the value-driven world that we live in terms of either direct or indirect metrics that are associated with advanced care planning. And ultimately, related to the unwanted utilization is really focusing on the value-driven world we live in and avoiding these unwanted costs. I wanted to just do a little survey in the literature around some of the benefits of advanced care planning when it is done right. This is a study that looked at patient satisfaction scores in both a primary care setting and an inpatient setting. And the intervention was an advanced care planning conversation. And what they saw was that the 5-star patient ratings increased from 34% to 51% in a primary care doc's office after having the conversation. And the particularly interesting point is that this was sustained in future visits, i.e., taking the time to have that patient feel like their values and preferences were being recognized led to a more solid relationship and a better experience going forward in subsequent visits. Similarly, on the inpatient side, having a discussion about advanced care planning also improved the 5-star ratings of that patient experience in an elderly population. There's also a substantial reduction associated with advanced care planning in terms of in-hospital death rates, increase in appropriate hospice use, and reductions in hospital admissions from the skilled nursing side or post-acute side. And you can see how many of these metrics and many of these benefits fit exactly into some of the key priorities that are being largely driven by our changing reimbursement landscape, and how advanced care planning can help organizations to achieve these metrics. But here's some statistics that outline the problem of the current state today. We know that nearly 40% of advanced care planning preferences contain a medical error when they're documented in the electronic health record. This was a large multi-center study done in elderly patients. Nearly 90% of the time, advanced care planning preferences are not available at the scene of an emergency. This is data from Oregon. And physicians have a very low confidence in their ability to locate advanced care planning information in the EHR to direct care. So we've taken a fairly holistic and end-to-end approach in solving this problem, and our belief is that this is such a complex but high-value process that it really deserves its own complete solution to really address the problem. And we think about it as we've laid it out here in terms of 4 components. The first is an engagement piece, which are a variety of technology tools that engage both patients, family members, and also clinicians in the process of having high-quality advanced care planning dialogues, providing them with the educational materials they need to understand these complex choices, and using guides that help clinicians to have these conversations in a high-quality way. We then have various tools to electronically capture and codify these wishes in both summary form, and we'll go into some of the options in a moment, but also in terms of the legally valid medical orders or advanced directive documents that may be available on a state-to-state basis. And we have some electronic signature technology that allows us to be rapidly captured without the need for credit card style signature pads and otherwise. We then aggregate all of this information in our secure cloud as a single source of truth, so that all of the wishes for a patient, regardless of where in the care ecosystem those wishes were created, that there is a version control accurate and aggregated piece of information and summary for those patients' future care preferences. And then finally, the honor piece. And as a clinician, I'm very focused on the clinical integration, making this a seamless tool for clinicians to use so that it ultimately will be adopted. So we've developed a very robust EHR integration strategy. You can see in this small schematic here that we have the capability of sending yes/no flags right into the patient banner bar to tell clinicians passively that there is documentation they ought to be looking at. And when the system opens within the EHR, it opens within the frame of the electronic health record so that the clinician is never leaving their workflow. And this is just another schematic of what I've just described, but we show this to say that there are various ways that individuals can engage with the system. Direct member and patient engagement tools that we can deploy through a patient portal or independently, a variety of ways that providers can interact with the tool, either through a direct web portal or various EHR integration strategies. And then we have a variety of light touch methods where organizations can choose some back-end integrations with us to send us their documents on an ongoing basis. This is all powered and aggregated by our proprietary patient matching algorithm that was recognized by the ONC in 2017 for its performance in terms of matching this patient data from across the care ecosystem. And then on the accessibility side, we have a variety of clinically integrated ways to make sure that this information gets to the right place at the right time. We recognize that there is a need, not only from a quality metric point of view, but from a quality improvement point of view, to have really powerful insights on both process and outcome measures related to advanced care planning. And we provide these reports to our clients on a monthly basis to help them understand where advanced care planning is being done, where perhaps there are opportunities to improve, and otherwise. There are several different document types that our solution manages. And on the left-hand side, we discuss some of the structured guides that we're able to manage. And these are essentially process-related tools that then result in a summary document being created. And these can be configured to an organization's own content. Sometimes if there is a robust palliative care program, there are a specific language or processes that are already in place that can be easily loaded into the system. We also have partnerships with evidence-based organizations to embed this content in a preloaded turnkey way. For example, Ariadne Labs, Tulgawande Serious Illness Guide, can be optionally loaded for clinicians that want to use that tool. And then finally, we have our base set of tools that can be used, and these address both healthier populations who perhaps are just needing to engage in values-based advanced care planning, identifying surrogate decision makers and reflecting on their general values for future care, as well as more serious illness guides that help to structure these difficult conversations around an individual's goals of care. We can manage advanced directives in the majority of states in a completely digital format. In certain states, there are regulations that prohibit digital completion of these documents, but thankfully that is a small fraction of the total states. And then finally, the life-sustaining treatment forms or medical order forms, the POLST form, do not resuscitate orders, and otherwise. And they all live in what we call our advanced care planning dashboard. And this is again, a cloud-based tool, web accessible through a variety of integration strategies. But essentially, we show in a simple color-coded format that person's most up-to-date wishes with respect to their future care preferences. And we also can categorize these documents by type so that a clinician can very quickly get a picture of what kind of discussions have been going on, what the context of those discussions has been, and has a trusted source of information to then go in and make treatment recommendations to the individual and their family. We have also developed a suite of member engagement tools, and we believe that this is a conversation that people want to have. And we developed a suite of these tools so that we can meet the member where they are, to allow them to go through self-directed advanced care planning processes, and also to engage their physician and make a request for an appointment to specifically talk about this. We have the ability to register patients either in a bulk state by, for example, age, disease state, or otherwise, or an embedded workflow for clinicians to proactively invite an individual during an appointment, for example, to have some advanced information, go through self-directed advanced care planning, and then talk about it at a future visit. And then we have a variety of engagement strategies that remind or prompt the individual to engage in advanced care planning, to revisit their options, and can provide reports on people that have partially engaged or not engaged, so that perhaps care management or other resources can reach out telephonically to follow up to answer any questions. And I had mentioned earlier our reporting tools. These are just some screenshots from some of the standard reports we provide, but we talk about general utilization, the number of documents that are being created. We can even look at things like how often emergency room providers are checking for the presence and the content of documentation for patients that have them on file. And we can map that ultimately to care concordance, looking at what a patient wants versus what they actually get, and by various care settings, either clinic type or unit discharge. And many of these, as I mentioned before, fit into some of the reporting requirements on the HEDIS side, certainly coming up in MACRA and MIPS that we provide back to our clients to help them achieve these various measures. So I wanted to talk a little bit about some of our case studies. This is a case study that shows some of our process-related success. This was our first implementation at Oregon Health and Science University, a large academic medical center in Portland. And what we saw in the first 6 months after we integrated our solution into the Epic EHR is that clinicians were accessing the system frequently, about 2,000 times on average per month. We saw a substantial reduction in the error rates on forms because we're completing them digitally now and can put in logic checks, error checking features, and simply don't allow forms to be created unless they are legally valid. So we saw that drop from about a 20% baseline rate in this particular center down to 0. And then we also showed that we were able to double the intake of advanced care planning documentation relative to the baseline, i.e. most of these documents previously were being filled out on paper, sent home with the patient, and then never captured for later access. We then took a system-wide analysis of all of our clients from 2015 to 2017 and looked at nearly 6,000 emergency room visits over that time period in people that had a so-called PULSE form. And the PULSE forms, just as a reminder, are medical order forms that are specifically meant for individuals with advanced illness, typically with a life expectancy of 1 year or less. And what we saw over this period was that there was a 37% reduction in hospital admissions and a 59% reduction in intensive care utilization when the Vinca tool was utilized to integrate care preferences into the plan of care in the emergency department. So great impact in terms of reducing unwanted healthcare utilization. This is not our own data, but it's an interesting snapshot of what the current state of end-of-life care planning is within ACOs today. And this was a look at a variety of ACOs, nearly 400 of them, to look at what was in place in terms of their end-of-life care planning processes. And what this survey saw was that just under 20% of ACOs had an advanced care planning program or process in place. The vast majority had some advanced care planning programs in place, and then about a fifth had no advanced care planning programs in place. And what this says is that there certainly is a need for more advanced care planning within ACOs. Certainly that 60% that have some investment in advanced care planning certainly have the opportunity to improve their outcomes and success through the adoption of a technology to streamline quality, reduce the variability. And for the organizations that have no advanced care planning programs in place, it is a real missed opportunity in terms of the ability to achieve these metrics that are so important. So ultimately, we see Vinca and the opportunity here to improve quality by reducing variability at the end of the day. And once again, this is the right thing to do for patients, and it happens to help organizations to achieve some of the metrics and goals that are increasingly important today, particularly in the ACO world. Accurate documentation and capturing that patient's wishes on an ongoing basis is of critical importance, particularly through these difficult conversations. And the rapid access across the care ecosystem is really critical to ensuring that these wishes are honored at the end of life. The tools that are required to do so support shared decision making within our system. And this is an incredibly important example of shared decision making to ensure that a patient is reflected on those values, and that then the clinician can provide their own expertise in providing and creating a go-forward plan. And ultimately, again, our goal and our vision at Vinca is to honor member wishes and patient wishes at the end of life, which is ultimately the goal of what we are all trying to do. So I will hand things back now to Garrett, to answer, and I believe we have some time for questions, but thank you very much for your time and the opportunity to present today.
All right. Well, thank you, Dr. Van Wert. So we have a few questions here that I wanted to address. The first being, and these are in no particular order, are there any actuarial analysis projecting the cost savings of ACP?
Yes, there are several, and we can certainly follow up with some of this information, but there have been a few systematic reviews and meta-analyses looking at cost savings in various settings, both from the risk-bearing entity's perspective and from the provider's perspective. In terms of actuarial analyses, this is something that is also available, and we tend to see this done internally at an organization where they will look at their overall cost of care or quality of care metrics and correlate that to, for example, the presence of an advanced care planning document on the chart. And with now several of our clients, they have done those internal analyses to recognize the importance of advanced care planning in terms of achieving their objectives, and often that is used as a driver to adopt and improve their advanced care planning program.
Okay, great. Next question is, what was the total population targeted on slides 15 and 16? So you may need to go back to there for reference.
So on in slide 15, this was just an overall analysis of a single academic medical center. In terms of the statistics on that medical center, they are a 528-bed facility, 30,000 or so hospital admissions per year. And in terms of the number of documents on file, we started with about 10,000 documents on file. This analysis was done right at the beginning of our implementation. So in that ballpark, that is the number of documents we were dealing with. And then in terms of the go forward numbers here, the 2,000 accesses per month was a metric just to say that you've got about 60 to 70 people clicking in per day at this single hospital as a metric of it being utilized frequently. The doubling of the pulsed form intake in this particular setting was from approximately 200 to 300 per month up to 400 to 600 per month that were being submitted. In this population here on slide 16, this was specifically ED visits, so patients showing up in an emergency department with a known medical order on file for their future care preferences, i.e. a pulsed form. And our control population was individuals where we knew there was a form on file, but the clinician did not check it. And then the intervention population was where we had the form and we detected that somebody logged into the system while that patient was in the ED, from the time they registered in the ED to the time they were dispositioned from the ED. And that's where we saw the change in healthcare utilization associated with the use of the system. So the assumption in this case, just to be clear, and the big assumption in this particular analysis is that the pulse form was being completed for a patient with a serious illness. So that the assumption was that the forms were completed for the appropriate population. So that is a limitation here. If a clinician, for example, filled out a form for a healthy 65-year-old, that's not necessarily an appropriate use of pulsed. But that was, from our analysis point of view, that was a limitation in that assumption.
Okay, great. Next question is, and we'll just keep going through these. Hospitals seem to be involved in ACP, but what have you learned about ACP engagement of SNFs and home health agencies?
Well, that's a great question, and I think the the post-acute environment in general is a very different environment from the acute care setting. And in what we're talking about here today, it's particularly relevant in terms of the adoption of, I will say, robust healthcare technology to support not advanced care planning, but their overall clinical workflows. So there are some challenges that go hand in hand with that. And then in that environment in particular, they're often dealing with limited resources from a physician perspective, a nurse practitioner perspective, and otherwise. So what we found in those care settings is that there's really two things that really matter. The first is just a really intensive analysis of the current workflows, identifying who in the building is having these conversations today, and when in the process of care are these discussions happening? Are they happening at admission, a change in condition, or otherwise? And learning from those processes and providing recommendations on best practices for how to codify the process of advanced care planning within those natural points of having the discussion in the population. On the home health side, it's relatively similar challenges, although I'll say in particular there are challenges around offline access and otherwise for having these discussions and leaving a document in the home. That's often a process where there is difficulty in getting copies back into the EHR if a document, for example, is completed on paper. But in general, our experience is that home health providers are more experienced and used to having these types of conversations as a normal part of their care. What we're doing to address both of those settings is that we have developed an integration with the market-leading electronic health record for skilled nursing facilities to break down as many of those barriers as we can on the technology side. And we also have in our pipeline some tools that we're developing that will facilitate offline completion of advanced care planning so that those clinicians can go through the process if, for example, they don't have in a self-service signal or a Wi-Fi to connect up to their home EHR system.
Okay, great. And kind of a follow-on question to that, do you find specialists are aware of ACP?
It's a great question. I think there have been a few studies around this. Certainly, I think everyone thinks about advanced care planning as it relates to oncology. And oncologists, certainly there's I would say a spectrum of awareness and engagement in advanced care planning. But what's, I would say, a bigger deficiency is some of the diseases that have a similar prognosis and a similar impact on quality of life to cancer, for example, end-stage renal disease, advanced heart failure, advanced lung disease. And literature has shown that these are often under-recognized populations where advanced care planning is so important. So a lot of the education that can go on at the specialist level is looking beyond just oncology and looking for these other populations where there is a true impact on prognosis and quality, and making sure that advanced care planning is engendered in those clinics and processes as well.
Okay. Next question is, how would an ACO stratify patients to outreach, et cetera, to first?
Well, I think there's a variety of approaches there, and certainly our belief is that particularly for the over 65 population, we should be trying to make a culture change amongst not only the clinicians but the ACO membership on the patient side, to make this a normal part of care. Just like you get vaccinations at a certain period of time, visiting your future care preferences should be a natural point in time. So our belief is that certainly at regular intervals, a Medicare annual wellness visit, at perhaps enrollment in Medicare or otherwise, that there is a natural stop and process built in so that people are having these conversations at a population level. And that is something that is critical so that when chronic or advanced illness develops, that these are not foreign concepts and people are comfortable having these discussions because they've already reflected on their values and they understand the importance of these conversations. In terms of looking at more specific populations, there's a variety of approaches to this, just depending on the amount of data that's available for the population. But you can essentially look at stratifying patients for outreach based, of course, on chronic conditions, prior healthcare utilization, and that's often something that we can get a snapshot at in terms of prior emergency room visits, hospital admissions, clinic visits. And it really comes down to where the organization is from a data strategy perspective and data availability perspective to identify populations that are the best candidates for more intensive advanced care planning because of their utilization or conditions.
Okay. And the next question relates to cost and expense. It says not all ACOs are large systems that do systemic work. What are the costs, and of course, who pays that cost?
We essentially try to keep our costs aligned with where organizations see the value. So typically, we will develop and work with the organization on an annual fee that supports their entire population, and it is tiered depending on the organizational structure to the size of the at-risk population, whether it's a Medicare population or otherwise. And that fee includes not only the full use of the technology tools, but a lot of what we're doing early on is a highly consultative process to ensure that the current and future state workflows are really aligned with adoption. And then along the same lines for at least the first 6 months, providing these reports back to the organization to make sure that adoption is going in the way that we see it. Typically, we will engage at a more of what I'll call a system level, and then disperse and make available the technology to any smaller practices that are participating within that broader ACO umbrella or otherwise.
Okay. Let's see, here's another question. Does Venka provide protocols that could be shared with an ACO physician membership?
Yes, absolutely. And that goes back to this slide here, where the structured guides are really a variety of tools that can support a clinician's discussion for advanced care planning. And these can be configured to the particular population type or otherwise. And then on the direct member engagement side, we can configure those tools to provide more values-based advanced care planning educational materials and otherwise that go into it. But the idea is that there are really some key themes that go into a high-quality conversation. Clinicians may not feel comfortable having it, so having the discussion. So these structured guides will contain prompts for how to approach a particular question, prompts on what these 4 or 5 key elements are to make sure that these goals of care discussions are being done in a high quality way.
Okay. We've got time for just a couple more here. So next question is, who are your current clients other than the ones that were highlighted in the slides?
Well, we have a variety of clients on the health system, ACO, and health plan side. In total, we have a presence in 11 states. We are managing close to 600,000 advanced care planning documents for patients at this time, and we are contracted with more than 80 hospitals. There is one other thing I'll mention is that I've spoken a lot today about our advanced care planning solution that can be adopted by an ACO, health plan, or health system. But one of the other important things that we do is we offer a state registry solution that is essentially something that a state will provide, and we are the vendor for that resource, so that any provider in the state can submit and access advanced care planning documents. And we have a presence in 5 states where we are operating the state registry as well.
Okay, great. And the last question here is, if an ACO did want to find out more about the revenue model and the expense to actually engage them, how do they go about doing so?
Well, I'll just put up the contact slide. You're very welcome to reach out to me, ryan@vincahealth.com directly. And otherwise, if you'd like to go to our website, vincahealth.com, we do have a contact us section there, and we will get back to you right away for any specific information. We also will be in Baltimore in a few weeks and have a table there, so please feel free to stop by and say hello.
Okay, great. Well, thank you, Dr. Van Wert. This has been very helpful. We'll go ahead and conclude now. And so for those of you who were not, our questions were not able to get answered today, we'll be sure to reach back out via email. But also, again, as if you have specific questions for Dr. Van Wert or the team, you can his contact information is right here on the slide, as he mentioned, his email and their website. So feel free to make a note of that and contact him directly. And lastly, be sure to visit the Vinca exhibit booth on ACOexhibithall.com. And to learn more about them and connect with their team and do a little bit more of a drill down there. So we'd love to have you there. And as he mentioned, lastly, Vinca will be at the NACOs conference in Baltimore, as will I. So I hope that I will meet some of you there face to face. But that concludes our webinar for today. So thank you all for attending. I hope you found today's presentation informative and helpful. You will receive a link to the recording via email. So that is it for now. Thanks for joining and have a great rest of your day.